Welcome back, everyone. We're starting today's lecture. Today's our PG lecture on pediatrics. This is our second lecture under a series of lectures under PG session under the Department of Medicine, DOMAT. Today's lecture is by Dr. Arul Premanand, Lionel. Sir is an associate professor in the Department of Pediatrics, Unit 1. Sir has completed his fellowship in pediatric gastroenterology also from the Children's Hospital, Melbourne, Australia. Also done a clinical fellowship in pediatric gastroenterology from Great Ormond Street Hospital, London. So has field of interest is basically pediatric gastroenterology. So has multiple publications under him and ongoing projects which are more than 10 in number. So we'll take today's session on approach to diarrhea and also vitamin A, D and zinc deficiency. This lecture is mainly meant for PG students or medical PG students who are preparing for exams, and also for others who are interested for so. The lecture will soon be uploaded on our Department of Medicine YouTube website. If any questions to the session, please feel free to ask or maybe put down in the chat box. Sir also has some clinical scenarios. If anyone interested can be responding to all the scenario questions or any doubts regarding that, please put up in the chat box. Thanks a lot, sir, for agreeing to take this lecture for us. Over to you, sir. Now, thank you.
Hi. Good evening, everyone. So today our topic is about diarrhea in childhood, and following that I'll be talking about vitamin A, D and zinc deficiency. So overview of this presentation, we are going to see the definition of diarrhea, etiology, pathogenesis, clinical features and clinical assessment of diarrheal dehydration, treatment, prevention, complication. So that will be like for the acute diarrheal setup, and then later I'll be talking about chronic diarrhea approach as well. So as you all know, definition as per like diarrhea in Greek, it means like flow through, but diarrhea is mainly defined as a change in consistency and frequency of stools. That is liquid or watery stools that occur more than 3 times a day. That is the definition. But however, the recent change in consistency and character of the stool is more important than the number of the stools. And if there is associated blood, then we'll call it as a dysentery. So what is not a diarrhea? So in children, there are some situation where we have to differentiate between diarrhea and not a diarrhea. So frequent defecation but with formed stools is common in children, and semi-liquid stools in a breastfeeding babies are common, and it's normal. And stool after feeding, that is in the infant age group, which is called as gastrocolic reflex, which is also not a diarrhea. And during the first 6 days of life, green liquid stools after birth is common. That is also normal. So these are all not diarrheas. And coming to the epidemiology of childhood diarrhea, that globally it is the second most common cause of childhood deaths. Secondary to first one is a respiratory infection, and it accounts for 9% of all under 5 deaths. And most of the deaths occurs less than 2 years old. And actually speaking, less than 5 years old get 3 episodes of diarrhea occurred per child year. And in India, it's 8% of deaths in under 5 age group. So the etiology, as you all know, like for acute diarrhea, its infection is the main cause. So bacterial infection like E. coli, Shigella, Salmonella, cholera, Campylobacter, Clostridium. So all these things are bacterial causes for diarrhea, and viral causes are most common in children. They are rotavirus, Norwalk, and other enteroviruses, and parasites like Entamoeba histolytica, Giardia, Cryptosporidium, and fungal causes are there. And parental diarrhea also is common when with other infections like otitis media, tonsillitis, any pneumonia that can cause parental diarrhea. And other than that, dietetic and nutritional, sometimes overfeeding and food allergy, food poisoning can cause diarrhea in children. And drugs like antibiotics, mainly amoxicillin, can cause drug-induced diarrhea, and non-specific diarrhea also is possible in children. So what are the risk factors for diarrhea in children? Poor sanitation and personal hygiene, and non-availability of safe drinking water, and unsafe food preparation practices, and low rate of breastfeeding and immunization, undernutrition, immunodeficiency state. These are all the risk factors for children to develop diarrhea. And modes of transmission, as we all know, it's a fecal-oral transmission, either waterborne or foodborne. And sometimes if there are direct contamination with the fingers and with the other fomites also can cause diarrhea in children. Before going into further into the topic of diarrhea. So what is a functional? I want to just briefly tell you about the functional anatomy of the gastrointestinal mucosa. So which has villi and the crypts. So the villi is having the main digestive enzymes and also transport protein. So at the brush borders. So any injury to the villi can cause diarrhea because of the defect of digestive enzymes and the transport protein lacking. And the tight junction between the epithelial cells, the villi, and then the tight junction between the epithelial cells that allows the water and electrolyte movements, and crypt is the area where the secretion can happen. So the water and electrolyte transport, it depends on few of this co-transporter and exchangers. So important ones are sodium glucose co-transporter, and sodium hydrogen exchanger, and chloride bicarbonate exchanger. So these are all important for the electrolyte and water absorption from the intestine into the interstitial fluid. So any problem here, like any mutation which causes this transport affected will cause diarrhea. That is like a congenital chloride diarrhea, congenital sodium diarrhea, and other things. And this part of glucose absorption, sodium absorption along with the glucose is important principle behind the ORS. So there are several mechanisms, there is several pathophysiology for diarrhea. One is osmotic diarrhea, where there is a non-absorbed osmotic load in the colon that can cause pulling of water along the intestinal lumen. And other mechanisms are secretory diarrhea, where there is an increased secretion of water and electrolytes into the intestinal lumen, more than the absorption of water and electrolytes. And inflammatory diarrhea, it's mainly the injury to the intestinal cells because of the inflammatory response. And motility alterations like hypermotility or hypomotility also can cause diarrhea. These are the mechanisms behind diarrhea. As I told, this osmotic diarrhea, it's mainly the increased osmotic load because of the osmotic substances in the bowel, which can pull the water and electrolytes from the enterocytes. But in secretory diarrhea, it's more of secretions rather than the pulling of water and electrolytes. Again, the same thing, it's a mechanism. But in the secretory diarrhea, it's more of activation of this cyclic AMP, cyclic GMP, which can actually cause the active chloride secretion and also blocks the sodium chloride absorption. And also there will be a toxin-mediated injury to the tight junctions, thereby causing more of secretions and secretory diarrhea. So how to differentiate between osmotic diarrhea and secretory diarrhea? So volume of the stools, in osmotic diarrhea, it's less than 200 ml per 24 hours. In secretory diarrhea, it will be a huge volume. It's more than 200 ml per 24 hours. And response to fasting, usually osmotic diarrhea stops by stopping the food or funding food. But in secretory diarrhea, even after stopping the food also, the diarrhea can continue. And stool sodium is less than 70 milliequivalents in osmotic diarrhea, but it's high in secretory diarrhea. And stool reducing substance, because of the acidic nature of the stools reducing substance will be positive, which will be negative in secretory diarrhea. So this acute infective diarrhea can be can follow one of these three mechanisms. One is adhesion to the intestinal mucosal wall, or by elaborating the exotoxin, thereby creating injury to the tight junction and causing secretory diarrhea, or mucosal invasion because of the exudative diarrhea. So coming to the viral pathogenesis, so most common is a rotavirus. So after the fecal-oral route, once that organism is inoculated in the human body, it infects the villi and the enterocytes, and thereby causing the sloughing of the villus and resulting in villus blunting. Once the villus blunting has happened, there is loss of absorptive function. So there is not much absorption and causes osmotic diarrhea. Also, rotavirus can produce secretory diarrhea because of the opening of the calcium channels. Thereby, calcium can enter into the enterocytes and sodium and water gets excreted. So this is the normal water and electrolyte transport along with glucose. This is the normal villi and crypt secretion can happen. But in case of acute diarrhea, what happens is a destruction of the absorptive surfaces. So thereby the absorption is affected here, and also hypersecretion can happen. Thereby causes imbalance between the absorption and secretion and causes watery diarrhea. So this is the rotavirus pathophysiology. So the rotavirus enters the enterocytes and the non-structured protein 4, which causes like break in the tight junction, and also it increases the calcium influx, thereby causes chloride and sodium efflux, and also water also follows this, and then diarrhea can happen. In bacteria, once the bacteria reaches the small intestine, it produces enterotoxin, that is mainly cholera toxin we are talking about, which activates the cyclic GMP and cyclic AMP, thereby causes a lot of fluid secretion. It also inhibits the absorption of sodium and chloride. So this is the pathogenesis behind the cholera toxin, labile toxin, and stable toxin, and E. coli associated stable toxin. All this activates the cyclic AMP and cyclic GMP, thereby causes a lot of chloride secretion. And other important infective etiology is Shigella. Shigella, there are various Shigella Shigella species that can cause diarrhea. Shigella, Shiga, Flexneri, Sony, Boydii, all those things can cause diarrhea. So here mainly they invade the Peyer's patch, and thereby it causes there they get phagocytosed, and thereby causes multiplication, and then they neutrophils can come in, and then they cause necrosis and degranulation, and thereby causes mucosal destruction and diarrhea. So this is the pathogenesis for Shigella. So where Shigella can come in, and then macrophage following by phagocytosis, neutrophils can come in and then destroy the tight junction. So clinical features wise, difference between viral diarrhea and bacterial diarrhea. Viral diarrheas are mostly more watery, and there will be severe vomiting also, and mild grade fevers can be there. In bacterial, it will be like if it's a non-invasive, not much blood, but if it's invasive, then mucus and blood will be there. And in invasive diarrhea, there will be a moderate to high grade fever, and also toxemia can be there. And the stool can show moderate pus cells and red cells also. So the history, it's very important, onset of diarrhea and blood in stools or not, episodes of vomiting, fever, cough, and other significant symptoms associated with diarrhea, and feeding during the illnesses, drug history, travel history, family history, immunization history. These are all the things that we need to give importance during diarrheal evaluation. And coming to the classification of the dehydration by severity, WHO has classified as no dehydration, some dehydration, and severe dehydration. And as no dehydration, if there is no any signs of dehydration. But in some dehydration, there are 2 or more of the following signs like restlessness, irritability, sunken eyes, drinks eagerly and thirsty, skin pitch goes back slowly, then it's some dehydration. In severe dehydration, either it could be lethargy, unconsciousness, sunken eyes, unable to drink, and skin pitch goes back very slowly, that is more than 2 seconds, then it's a severe dehydration. It's again the same thing, it's a different table. So we have to assess those by sunken fontanelle. A child can have sunken fontanelle and also sunken eyes, and reduced level of consciousness, dry mucous membrane, and reduced tissue turgor, and also tachypnea. If it's an infection, child is having fever, there may be tachypnea. But sometimes when they develop the acidosis, they may have a slow breathing, also acidotic breathing, and they may have oliguria, and then weight loss, tachycardia, hypotension can be there. So what is the principle behind the treatment? 4 major components of therapy. One is rehydration and maintaining the hydration. Second thing is nutrition and also feeding, and oral zinc supplementation, and also recognition of the danger signs and treatment of the complications are the principles behind the diarrheal treatment. So as we all know, WHO has classified this as a plan A, plan B, plan C based on the dehydration status. So plan A is ORS. Again, it's for no dehydration. So we have to give ORS. At the same time, we have to, it's like a home management. We can send the child on ORS, but at the same time, we have to explain to the mother about the danger signs. That is diarrhea beyond 3 days, and then also increased volume or increased frequency of stools, any blood in stools, any repeated vomiting, fever, or refusal to feed. All those things are danger signs. The mother has to bring the child immediately. So this is the plan A for ORS therapy for no dehydration. So if it's so this is the first column is for the fluids to be given after each stools, and second column is for amount of ORS to be provided at the home. So after each stools, it should be like for less than 2 years, it's 50 to 100 ml after each loose stools. For 2 to 10 years, it's 100 to 200 ml after each loose stools. More than 10 years, they can take how much ever they want. And zinc supplementation also is essential part of treatment. And plan B is some dehydration. It's usually 75 ml per kg of ORS to be given over 4 hours. This is a holiday cigar formula that is for all the fluids that we uses. And then we have to, at the same time, we have to replace the losses also with 10 ml per kg of ORS after each stools. And plan C is IV fluids, that is severe dehydration. So we may have to give bolus if needed, and then followed by that 100 ml per kg of IV fluids. If the child is less than 12 months, it should be given over 6 hours. If the child is more than 12 months, it should be given over 3 hours. So the first 30 ml per kg should be given over 1 hour in less than 12 months, less than 1 year. And if it's more than 1 year, it should be given over 30 minutes, and then remaining 70 ml over 5 hours and 2.5 hours in different age group. And then based on the then we have to reassess the dehydration status, and based on that we have to decide whether we have to go to plan B, plan C, or we have to downgrade the plan B to plan B and plan A. So ORS mechanism is basically, I told you earlier, it's because of the sodium gradient that is maintained in the intestinal cells. So mainly because of the passive sodium diffusion, and also active co-transport of sodium along with the glucose. But in diarrhea, this part is affected, that is passive sodium diffusion is affected, but this one is preserved so that we can give glucose to get the sodium and water absorbed into the enterocytes. So coming to the ORS, I put up one slide on ORS. That is one is standard WHO ORS, which is formed for cholera diarrhea for the cholera. So which has a high osmolarity rate. So here 311 is the osmolarity. So which causes like high osmolarity again can produce more diarrhea, and hypernatremia is a complication because sodium is very high. But in reduced osmolarity ORS, the glucose and sodium content has been reduced to 75 millimoles per liter, and the total osmolarity is 245. So what are the advantages of this reduced osmolarity ORS? It's mainly effective water and sodium absorption is there, and hypernatremia can be avoided, and the taste is good, and also the purge rate is also less when compared to the standard ORS. And other home available fluids also can be given at home. That is, fluid contains salt, that is ORS, salted drinks like salted rice water, yogurt, and a vegetable or chicken soup can be given along with salt. Even without salt also those things can be given. Plain water is also is okay. If there is nothing else is available, water can be given, and tender coconut water also can be given. But these products like commercial carbonated beverages, fruit juices, sweetened tea should be avoided. And what are the other measures that can be done during acute diarrhea? Zinc supplementation, that is 20 mg per kg for 10 to 14 days is recommended. Probiotics, there is no much evidence to say like probiotics is very useful in acute diarrhea. And anti-motility drugs is not recommended in children. And resicodratril, it's also like there are different studies, and some accept that resicodratril helps in reducing the purging of stools, but most of the time it's not necessary. And antibiotics is not necessary unless if it's infective diarrhea, then we have to use antibiotics. And we should continue the nutritional management in children, mainly continue breastfeeding, and also avoid food with a lot of sugar, oil and fat. And high fiber should also be avoided at the time of acute diarrhea. And once the recovery is starting, then we have to increase the RDA to 125%, thereby increases the energy dense food. And coming to the complications of diarrhea, it's mainly because of the dehydration, with the complications like renal shutdown, paralytic ileus, thromboembolism, seizures are some of the complications of acute diarrhea, and superadded infection, malnutrition, and electrolyte imbalance, hypoglycemia, and also SAIDH can occur, and toxic megacolon are some of the complications of acute diarrhea. So prevention is mainly promotion of breastfeeding, and complementary feeding practices should be encouraged. Immunization should be encouraged, and improve the sanitary facilities and water sanitation, and promotion of personal and domestic hygiene, and improved case management of diarrhea. Okay, so that is about acute diarrhea. So now I'm going to talk about a few slides about approach to chronic diarrhea, because chronic diarrhea also is more common in children. So what is the definition of chronic diarrhea? If diarrhea exceeds more than 4 weeks. Persistent diarrhea, if the diarrhea starts as an infective origin and then persists for more than 14 days, then we call it as a persistent diarrhea. But chronic diarrhea usually may not be infective in origin. Having said that, but infection also can produce chronic diarrhea. So the causes for chronic diarrhea, again, infective causes we should think of. And other thing is like a functional diarrheas, like idiopathic, or excessive carbonated fluid, or excessive intake of laxatives, and irritable bowel syndrome are some of the functional causes for chronic diarrhea. And other than that, we should think of immunodeficiency, whether it could be a primary or secondary immunodeficiency, or abnormal immune response like celiac disease with gluten sensitivity, and fruit protein induced enteropathy, and autoimmune enteropathy, and graft versus host disease in children who has undergone BMT and other transplants, and inflammatory like Crohn's disease, ulcerative colitis, and the early onset inflammatory bowel disease should be suspected. And other causes like protein losing enteropathy is the other cause for chronic diarrhea, which usually caused by lymphangiectasias of the gut, and neuroendocrine tumors can produce chronic diarrheas, and also abnormal digestive process, that is cystic fibrosis, and Shashwan-Diamond syndrome, Johnson-Blizzard syndrome, isolated pancreatic enzyme deficiency. All this can produce fatty steatorrhea, that is fatty stools. And the other big chapter is a congenital diarrhea. I'm not going into that as such, but I want to mention some of the disease of the congenital diarrheas. That includes sucrose isomaltase deficiency, lactase deficiency, glucose galactose malabsorption, fructose malabsorption, and congenital chloride and sodium diarrhea, acrodermatitis enteropathica, microvillus inclusion disease, tufting enteropathy, A beta lipoprotein. These are all some of the congenital diarrhea, causes for diarrhea. So pathophysiology, again, it's osmotic, secretory, and some of the mutation in the apical transport proteins that we discussed. So, and also reduction in the anatomical surface area, and intestinal motility has been affected. All these things can produce pathophysiology behind the chronic diarrhea. So evaluation starts with 4 main clinical features, that is age of onset of diarrhea, and pattern of weight loss, and also character of the stools, whether it's a watery stools or malabsorptive stools or inflammatory stools, and also associated symptoms. The associated symptoms is very important. And also this stool character also is very important to categorize the diarrhea, whether it's like a inflammatory diarrhea or a infective diarrhea, other things. Okay. So this is a list of chronic diarrheal, like etiology for chronic diarrhea for the infant, and also between 2 months to 2 years and 2 years to 18 years. So if you can see what are the congenital etiology, all in the early age group, and also in 2 months to 2 years, it's more of post-infectious diarrhea, celiac disease, food allergy, cystic fibrosis. All these are common in this age group. And 2 to 18 years, it's again more of like an infection, celiac disease, irritable bowel syndrome, and inflammatory bowel disease are common in this age group. So stool features, as I told, like say if it's like a odorless blood-tinged stools, it's more of infection. But if it's like a mucoid stools in a healthy child without any blood, then we should think of irritable bowel syndrome. And if it's like a explosive watery diarrhea, then it's a carbohydrate malabsorption we should think of. And fatty or oily stools is straightforward, we should think of fat malabsorption. Mucoid bloody stools could be an infective or an inflammatory, like IBD. If it's like a chronic diarrhea with a history of delayed passage of meconium or constipation preceding the diarrhea, then we should think of Hirschsprung disease, because bowel dysmotility also can cause diarrhea, which can be a overflow incontinence because of the constipation. And other associated symptoms, if there is no symptoms, well child, then we should think of toddler's diarrhea or irritable bowel syndrome also. If it's like abdominal distension and weakness, celiac disease has a spectrum of clinical features. It can be from like mild illness to severe illness. It can produce anemia, ascites, and severe hypoalbuminemia. So abdominal distension and weakness, we should think of celiac disease. And recurrent respiratory tract infection again gives us clues towards cystic fibrosis. And severe abdominal pain, bloody diarrhea, and oral ulcers, then we should think of inflammatory bowel disease, and TB also, TB, intestinal TB. And also vomiting with rash and allergic episodes, then we should think of eosinophilic enteritis. And yeah, in fact, with severe napkin dermatitis, then we should think of acrodermatitis enteropathica also. And when they are associated with allergic dermatitis, then we should think of cow's milk allergy and eosinophilic enteritis also. Family history is very important because food allergy can be run in families, and also celiac disease can run in families, and cystic fibrosis and IBD can run in families. And other congenital diarrheal disorders like microvillus included disease can be associated with consanguinity also. And we should record detailed diet history because sometimes it gives a clue mainly to rule out like cow's milk intolerance, and also sometimes they start the gluten early. Maybe at the time of weaning they would have introduced some gluten diet, which would have triggered the gluten enteropathy, celiac disease. And overfeeding and concentrated formula also can produce osmotic diarrhea. And drug histories like prolonged use of antibiotics or any steroids can produce pseudomembranous colitis that we should give attention. And examination, mainly height and weight is very important because malnutrition can occur. Or in otherwise non-specific diarrhea and IBS, height and weight will be usually normal. And also if there is associated anemia, then we should think of cystic fibrosis, celiac disease. If there is associated fever, then we should think of infection, TB, and also IBD, immunodeficiency. And hyperpigmentation gives clues that it could be a celiac disease or a Addison's disease. Addison's disease can produce parental diarrhea also. And generalized lymphadenopathy can gives rise to a suspicion of lymphoma or any tuberculosis. And also the scaly lesions around the mouth and also around the anal region can we should think of acrodermatitis enteropathica. And with the oral ulcers, stomatitis and fistulas, then we should think of Crohn's disease. And hepatomegaly, again lymphomas, cystic fibrosis, IBD. And abdominal distension could be secondary to true obstruction or could be a pseudo obstruction or malabsorption. So we should, based on the investigation, we should differentiate those things. And ascites can occur in TB, lymphoma, and having said that, in celiac disease also we can, a child can have ascites. So what are the red flag signs in diarrhea, in chronic diarrhea? So mainly it's nutrition, poor weight gain and weight loss, continuous diarrhea, night symptoms, acidic stools, blood or mucus in stools, and also associated symptoms like fever, rash, and arthritis. These are all the red flag signs for chronic diarrhea. So I think everybody is following this. Coming to the diagnostic evaluation. So main thing is history and examination, including the nutritional status is very important in children with chronic diarrhea. And first evaluation, basic evaluation should be stool reducing substance and smear and culture of the stools, stool fat globules and stool parasites. And also we should look for anemia and also electrolyte imbalance and inflammatory markers like ESR, CRP. Albumin will be mostly affected if it's like a chronic problem. So we have to do an albumin as well. And coming to the second line investigations, more towards specific etiology. Then we have to do a hydrogen breath test to look for any food intolerance, like mainly lactose intolerance. And stool fat test, 72-hour stool fat test is very, not very practical, but it's a very good test. And stool elastase will give us an idea whether it's a pancreatic insufficiency, and sweat chlorides to rule out cystic fibrosis, stool calprotectin for IBD, lipid profile mainly in A-beta lipoproteinemia. There will be a hypotriglyceridemia, hypocholesterol. So all these things can be addressed. And anti-DDG to look for celiac disease. This is the second phase of investigations. And next line of investigations include imaging. That includes ultrasound, and CT or MR angiography give us an idea whether it's like any inflammatory bowel disease or any strictures, any obstruction we can find out. And also albumin tag scan will give us an idea about whether there is a lymphangiectasias, intestinal lymphangiectasias. And then endoscopy studies with mucosal biopsies will give us a clear idea to differentiate between various diseases, including inflammatory bowel disease. We can do a TB workup also from the mucosal biopsies. And also electron microscopy, mainly to look for any congenital causes for the diarrheas, like tufting enteropathy, microvillus inclusion disease. And lastly, motility and electrophysiological studies, including manometry for dysmotility problems. And then last, if like it's also like relatively important, doing hormone studies like urine metanephrines and vasoactive peptides, and thyroid function test, ACTH. These are some of the hormones that can produce chronic diarrhea that we need to evaluate. And finally, nowadays a genetic test is available, so we can do a whole exome sequencing or a genetic test to look for any particular cause. Mainly it's useful in monogenic IBDs and also congenital diarrheas. So far we talked about so many causes of chronic diarrheas and also talked about acute diarrheas. So I just want to give some few clinical scenarios before going to the next topic, vitamin deficiencies. So if anyone interested, I can stop for a few seconds. If you want to answer, you can answer. Otherwise, I'll go through the slides. So case one, it's a 13-year-old boy from Chennai. Parents are IT professionals. And child has come with recurrent loose stools 10 to 15 times per day, and also abdominal pain for the last 9 months. And the stool consistency varies from normal to watery stools, and there is a history of urgency for defecation. And no blood or mucus in stools and no night symptoms. And he was also diagnosed to have mild ADHD, and he is on follow-up for that. Father also has intermittent loose stools and abdominal pain. On examination, his hydration was adequate. There was no anemia. His weight is at 70th centile and height is at 75th centile. Systemic examination was normal. So anybody would like to answer, like what will you do next step for this child? Okay. So we'll do a basic test as first line of investigations, that is counts, ESR, CRP, and albumin. So why? Mainly to rule out there is no other, like it's not. It looks like more like a non-specific diarrhea or a irritable bowel syndrome, because the child's height and weight is normal, and there are some clues for the IBS also, because this child is having abdominal pain and recurrent loose stools, but it's not affecting his nights like sleep. He's sleeping good, and father also has some features of irritable bowel syndrome, and his height and weight and everything is normal. So just to rule out there are no underlying pathology, we have to do an inflammatory marker, ESR-CRP, to rule out IBD, which is a close differential for IBS. And if its albumin is normal, then there is no need to worry. And stool routine parasites, microscopy, fat globules. So for this child, it's all normal. So coming to this approach of chronic diarrhea, so when there is weight and height normal and nutritional status normal, then it's very much like a non-specific diarrhea or a irritable bowel syndrome or carbohydrate malabsorption. So it goes in that direction. But if weight loss or weight loss with other signs of inflammation, then we should actively investigate with the non-invasive investigations, and then go for the scopy and diagnostic findings. So for this child, it could be probably it's a irritable bowel syndrome. So irritable bowel syndrome clinical presentation is abdominal pain and change in bowel habits and normal growth, and it's a diagnosis of exclusion. Although there is no need to do all the tests, but at least basic test we have to do to make sure that this is not an IBD. And there will be a positive family history. Treatment, it's mainly behavioral therapy, sometimes antispasmodic and antidepressants, and sometimes probiotics also can help. Second scenario, so it's a 14-year-old boy from Bangladesh who has come with a history of abdominal pain and loose stools for 4 months. It was mucoid stools, 6 to 7 episodes per day, and intermittent blood in stools is there, and night symptoms also there, 1 to 2 night symptoms also there, and intermittent fever and oral ulcers are there. History of weight loss of around 4 kgs in this 4 months. So he has pallor, he has oral ulcers, skin was showing this type of picture. So this is erythema nodosum. It's a painful, tender skin nodule. And abdomen examination was mild tenderness in the right iliac fossa. Anybody wants to add like what you want to do for this child? And any diagnosis you are suspecting, any other diagnosis for this child for his chronic symptoms?
You can either voice out or type down in the chat box.
Okay, thank you. I'll move on to the next slide. So for this child, a basic blood test showed anemia and also mild thrombocytosis, which says there is an inflammatory process going on, and also noticed to have raised ESR and CRP, which are the inflammatory markers, and also hypoalbuminemia. As I said, it's a marker of chronic disease. So stool calprotectin was done, which was very high, and also CT and MR enterography can be done to look for the involvement of the like bowel, and also upper and lower GI scopy with mucosal biopsy is important to diagnose inflammatory bowel disease in this child. So inflammatory bowel disease, again, general clinical characteristics are weight loss, abdominal pain and diarrhea. And there may be a fistula, or there may be like abscess formation in the anal region, and skin tags can be noted in the anal region, and positive family history may be there. And laboratory findings, mainly elevated inflammatory markers, anemia and hypoalbuminemia. The evaluation is small bowel imaging with MRI and also endoscopy and biopsy. Treatment is again anti-inflammatory medications, immunosuppressants, biologicals, if needed, surgery. Case 3, it's a 5-month-old infant born to consanguineous parents. There is a history of poor weight gain since birth, and there was intermittent loose stools, otherwise passing foul-smelling stools 5 to 6 times a day, and faulty feeding also is there. Past history of admissions, 3 months of life with an LRI. There is a significant history of sibling death with recurrent respiratory infections and failure to thrive. So on examination, this child was noticed to have evidence of protein energy malnutrition. Weight is 5 kg. There is generalized edema and anemia. And abdominal distension also was there. And liver is 4 centimeter patho. And counts were showing anemia. Serum electrolytes were showing hyponatremia, low albumin, and stool fat globules positive. Any differential for this child? Who is 5-month-old with poor weight gain and also loose stools, having foul smelling stools, and previous there is a history of LRA, and previous sibling had recurrent episodes of infection. Cystic fibrosis. Yes, there is type for that. You're right. Cystic fibrosis is the differentials. Then next step, what we'll do, sweat electrolytes and also stool elastase to look for pancreatic insufficiency. Throat swab as an additional one, because most of the time there will be the throat will be colonized with unusual organisms. And gene mutation for cystic fibrosis is the next step. So fat malabsorption usually caused by pancreatic insufficiency. Most common cause in children is cystic fibrosis. And as we discussed about the evaluation, and treatment is pancreatic enzyme supplementation. So whatever we discussed, this is a flow chart. You can go through the flow chart later. It's the same thing that what we have discussed, how to approach that as a flow chart. It will be useful for your theory examination. And other therapeutic approaches for chronic diarrhea include supportive measure, nutritional rehabilitation, and elimination of diet sometimes will be helpful, and drugs, and treat the underlying cause. So always better to, if it's like infant having chronic diarrhea, better to start with lactose-free diet. And also sometimes with refractory and intractable diarrhea, semi-elemental and elemental diet will be helpful. That formulas are available, commercial formulas are available for that. And most preferable method is enteral nutrition. Sometimes we have to give NJ or gastrostomy feeds. And if it's not possible, if the child is having ongoing weight loss, then we have to think of parenteral nutrition also. And micronutrient and vitamin supplement also is a part of nutritional rehabilitation. Drug usually based on the underlying problem. So antibiotic if it's like suspected infection, and immunosuppression if for autoimmune enteropathy and inflammatory bowel disease. And resicodratil, usually it's not recommended, but sometimes it will be useful also. And other neuroendocrine tumors which are producing this enterotoxins, we can try somatostatin analog like octreotide, and zinc can be supplemented also. In congenital diarrhea, it's very difficult to treat when other attempts like whatever we have talked about like TPN and other things, if it's not working, then the next step is intestinal transplantation is the option for congenital diarrhea, which is not very much available in India. That's about diarrhea. Anybody have any doubts? Then next I'll go to the vitamin deficiencies, that particularly vitamin A, D, and zinc deficiency. If anybody have any questions about diarrhea. Okay, I'll move on to the next topic. Oh, sorry. So vitamins are essential nutrients, and they needed only in the small amount for our body, and it cannot be biosynthesized in our body, so it has to be supplied by diet or as a supplements. And broadly divided into two groups, that is fat soluble vitamins A, D, E, K, and water soluble vitamins, that B and C complexes. So coming to the vitamin A deficiency, so vitamin A refers to the alcohol form of the vitamin, that is all trans retinol. The storage form of vitamin A is retinol palmate, and also the aldehyde form of the vitamin A is retinol, which is useful in the functions in the vision. And also the most important is the retinoic acid, which is functions at the gene level. So what are the functions of vitamin A? It's essential for the normal vision because its integrity of the eye and formation of rhodopsin is necessary for the dark adaptation. And also it's mainly important for the integrity of the glandular and epithelial tissue, and also important in immunity, mainly for activation of T lymphocytes and maturation of white blood cell counts, and also important for growth and development. What are the sources? There are animal sources and plant sources. Animal sources are mainly preformed vitamins, that is retinol. So it's and plant source is provitamin, that is beta carotene, which is a precursor of vitamin A. So it's mainly green leafy vegetables and other fruits and vegetables. So the animal foods like liver, egg, butter, cheese, whole milk, fish and meat are the good source of vitamin A. And plant food, mainly green leafy vegetables and other fruits, avocados, and sometimes fortified foods with vanaspati, and milk also sometimes fortified with vitamin A. So what is the ICMR or RDA of vitamin A? So as you see, like from infants up to 6 years, it's around 300 to 400, and beta carotene is 1200 to 1600 micrograms. But as after the age of 6 years till pregnancy, it's the same, like it's doubles. 600 for retinol, and if at all, then beta carotene 2400. But during the lactation, a mother needs high vitamin A, that is 950, and beta carotene of 3800. So what is vitamin A deficiency causes? It mainly the ocular changes, that is night blindness and xerophthalmia. And other than ocular changes, there are other effects also, like growth retardation and acquired immune deficiency, and anemia also is possible. So what are the challenges? Now it's vitamin A deficiency is one of the leading cause for preventable blindness in children, and also it increases the risk of disease mortality and also death because of severe infections, particularly diarrheal disease and measles. With that, associated vitamin A deficiency can cause much severe problems, and it's a public health problem in more of the developing countries, mainly affecting the children and pregnant women. So ocular manifestations, as per WHO, it has been classified as night blindness, then conjunctival cirrhosis, and then 1B is conjunctival cirrhosis with white dot spots, 2 is corneal cirrhosis, 3 is corneal ulceration, 3A is if it's less than 1/3 of the cornea involved, 3B is if more than 1/3 of the cornea involved, and XF is xerophthalmia fundus, and XS is corneal scar. These are some of the pictures. This is the white spot, which is foamy white areas on the bulbar conjunctiva of the eyes, and corneal cirrhosis and keratomalacia. So what is conjunctival cirrhosis? Night blindness is the first symptom of vitamin A deficiency, and first clinical sign is conjunctival cirrhosis. The conjunctiva becomes dry and also lusterless, and become less shiny and smooth. Bidot spots is a triangular pearly white or yellowish foamy spot on the bulbar conjunctiva. And keratomalacia is a liquefaction of the cornea. It's an ulceration which affects the cornea, and which is a very much risk for losing the vision. So mostly associated with malnutrition. So other symptoms of vitamin A deficiency is dry and rough skin, and also brittle hair and nails, and lack of smell and taste sensitivity, sense, and also loss of appetite, and poor growth and low immunity. Because of that, recurrent infections are common in vitamin A deficiency. So what is the treatment? Treatment is usually, if it's like severe illness or associated with malnutrition, then we have to give 1 lakh international units of vitamin A on 2 consecutive days. In other than severe illness, if it's a non-corneal xerophthalmia, if it's like only conjunctival involvement and bidot spots, then otherwise healthy and well-nourished children, we can give oral vitamin A also. If it's less than 14 years, 1 lakh international units. If it's more than 14 years, 2 lakh international units as a start dose. And other measures, we have to do a keratoplasty if at all the child has gone in for a keratomalacia. So this is a WHO recommendation for children at risk. That is mainly wherever the vitamin A disease is endemic, they would like to give vitamin A supplementation for they divided the age group of 6 to 11 months and 12 to 59 months. For 6 to 11 months, it's 1 lakh units vitamin A once, but for older children, 2 lakh international units every 4 to 6 months. So what they found out from WHO study is it reduces the mortality by 23%, and also it reduces the death from measles by 50% and death from diarrhea by 40%. And the toxicity when excessive intake of vitamin A can cause dermatitis, hepatosplenomegaly, and bone fractures, and also pseudotumor cerebri, which can present like an aseptic meningitis. So that is about vitamin A deficiency. Coming to vitamin D deficiency. So vitamin D is very important for calcium homeostasis as well as bone health. And severe vitamin D deficiency can cause rickets and hypocalcemia in infants and children, but osteomalacia in adults and adolescents. Severe vitamin D deficiency in children can sometimes causes hypocalcemia, thereby causes tetany and seizures also. So as you all know, like vitamin D is synthesized from the cholesterol, that is mainly after the sunlight exposure. The cholesterol in the skin, that is that is being converted into 7-dehydrocholesterol, which is a precursor for vitamin D3. Sources of vitamin D, mainly sunlight is the most important source, and fish liver oil and seafoods, egg, and fortified milk and other food items can be a source of vitamin D. Functions, mainly vitamin D helps in absorption of calcium from gut and renal tubules, and also its main function is cell differentiation, particularly collagen and skin epithelium. And immunity, it's important for cell-mediated immunity and other immune responses also. So metabolism, as I told, 7-dehydrocholesterol after exposure to sunlight has been converted to vitamin D3, and also from diet also we can get vitamin D3 and vitamin D2, which can be converted into calcidol in liver, and then later from kidney it has been converted into calcitriol and then inactive metabolites. And calcitriol increases the intestinal absorption of calcium and also increases the bone resorption and also decreases the calcium excretion. So who are all the groups of people who are at risk for vitamin D deficiency? So infants and elderly, and also dark skin people, and kidney chronic kidney disease and liver disease, fat malabsorption. All those children are at risk for vitamin D deficiency. So what are the other fat malabsorption, particularly in children, like pancreatic insufficiency, cystic fibrosis, chronic liver disease, celiac disease, and Crohn's disease can produce vitamin D deficiency. And the same thing. So how to define the vitamin D deficiency? So vitamin D, there are various numbers that has been proposed, but as per Pediatric Endocrine Society, the vitamin D sufficiency is 20 to 100 nanogram per ml. Vitamin D insufficiency is between 12 to 20, and if it's less than 20, it's like deficiency. We call it as deficiency. But here we are following, I think, 20 as a cutoff. So what are the clinical manifestations? As you all know, like vitamin D deficiency can produce rickets in children. So younger children may manifest as like delayed closure of fontanelles, craniotapes, frontal bossing, and also prominence of costochondral junctions, that is called as rachitic rosary, and also widening of the wrist and ankles and bullets. In older children, it can produce osteomalacia, which can manifest as generalized muscle and bone pain. So in children with vitamin D deficiency, we have to look for signs of rickets, and these 10 signs that is mainly delayed closure of the fontanelles, wide sutures, craniotapes like sutures are not fused and gives a crackpot sign type of feel, and frontal bossing, dental hypoplasia, rachitic rosary, Harrison sulcus, pectus carinatum, and widening of the wrist and ankle joints and bowing of the legs. These are all the main manifestations of rickets in vitamin D deficiency in children. Investigations, mainly we have to do a 25-hydroxy vitamin D level, which is a diagnostic. And other than that, renal function, liver function test, and sometimes anemia can be associated with vitamin D deficiency. And other thing is calcium phosphate alkaline phosphatase and parathyroid hormone to look for the secondary hyperparathyroidism and other things. So radiologically, yes, there will be a widening of growth plate, and there is a cupping and fraying of the metaphyseal ends, and also generalized reduction in the bone density can be there. So investigation wise, there will be a low vitamin D3 level and elevated serum alkaline phosphatase level. Calcium level may be normal or low, and the phosphate also usually normal to low. How to prevent? How to prevent the risk factors? We should encourage this sunlight exposure and vitamin D supplementation, food fortification, and normal calcium intake are some of the measures that we have to do. So how to prevent supplementation for infants? It's 400 international units for all the exclusively breastfeeding infants. We have to give 400 international units is the recommendation, and 1 to 18 years 600 international units. And some supplementation of the lactating mother can we can avoid supplementing the infant. So this is like moderately high dose we have to give for the lactating mother, 4,000 to 6,400 international units per day. And exposure to sunlight is important, but in light-skinned individuals, it's 10 to 15 minutes of sun exposure is enough. But in dark-skinned people, we may not, and winter season also can produce it cannot synthesize much vitamin D. So we have to give dietary sources for these children. And when we diagnose with vitamin D deficiency or insufficiency, we should treat the children with more than 12 months old, 2,000 international units for a total of 6 to 12 weeks, or 50,000 international units per week for 6 weeks. And this should be followed by the maintenance dose of 600 to 1,000 international units per day. And the children with established rickets need somewhat a higher dose of treatment, that is 3,000 to 6,000 international units for children more than 1 year up to 12 years, and 6,000 international units for children more than 12 years old. This should be given for 12 weeks. And then there is something called Stoss therapy, which is very much useful in children who are not very adherent to the treatment, and it should be like a high dose in divided doses, 2 to 4 divided doses. Recommendation is 1 day, but what we usually practically following is 3 to 4 days time. We can give this 3 lakhs to 6 lakh international units of vitamin D. So what IAP says, this is the flowchart of IAP. For Stoss therapy, again, it's 1 lakh to 6 lakh, but preferably 3 lakh units for all the age group for over 1 to 5 days. Other than vitamin D supplementation, that is important to treat the hypocalcemia also, because sometimes children may be symptomatic with hypocalcemia with seizures and tetany. So we should supplement with calcium also. Mainly if they have seizures, we should start with intravenous calcium and then change to oral calcium supplementation. And sometimes directly giving calcitriol for a short time of 2 to 3 days also will be helpful. The usual dose of calcitriol is 0.05 micrograms per kg per day. Again, vitamin D toxicity can cause like hypercalcemia, hyperphosphatemia, and hypertension. So which can manifest as nausea and vomiting, and excessive thirst, severe itching, joint and muscle pain, and stones and ectopic calcification. And sometimes it can produce disorientation and coma also. Coming to the last topic, that is zinc deficiency. Zinc is having many functions in our body, mainly for the metabolic process. And also this zinc deficiency is common in developing countries, and it's more common in the complementary food mixtures. So infants who are fed with this complementary food may have zinc deficiency. So the dietary sources, mainly all this seafood like oysters, nuts, shellfish, and also meat, eggs, and milk products has zinc. So its functions is mainly as a cofactor for other enzymes, and also cellular function level like growth and cell development, and also tissue growth and repair, wound healing, and also immunological functions also is there for zinc. And other functions, endocrinological functions like thyroid function, pancreatic function, prolactin secretion. So for all those things, zinc is essential. And also neurological functions like cognition, memory, also zinc is essential. And coagulation factors and bone mineralization also, zinc is essential. So zinc deficiency, what are the etiology? It's a dietary poor intake of zinc from diet, and malabsorption, and burns, chronic renal disease, and other diarrheal disorders like acrodermatitis enteropathica, chronic disease, Crohn's disease, cystic fibrosis, and other chronic liver disease can produce zinc deficiency. So mild zinc deficiency can be produced like depressed immunity and recurrent infection and impaired taste and smell. Moderate can produce growth retardation and hypogonadism, and also delayed wound healing and night blindness. Severe can produce severe immune suppression and frequent infection, and then acrodermatitis enteropathica. So what is acrodermatitis enteropathica? It's autosomal recessive disorder. It's mainly there will be like erythematous and vesiculobullous dermatitis because of the zinc deficiency. Other associated features are alopecia, ophthalmic disorders, diarrhea, growth retardation, and delayed sexual maturation. And neuropsychiatric manifestations also occur in acrodermatitis enteropathica. Usually the zinc dose should be high for acrodermatitis enteropathica, which should be 3 mg per kg per day of elemental zinc should be supplemented. So the acrodermatitis enteropathica picture of a child. Blood investigation, usually zinc can be checked in plasma, but more useful one is from the lymphocytes and neutrophils. And if it's less than 60 microgram per deciliter in plasma, then we call it as a zinc deficiency. And hypoalbuminemia sometimes causes a decreased level of the zinc. So treatment, it's elemental zinc replacement. For infants and children, it's 0.5 to 1 milligram per kg per day. And if there is a diarrhea and other malabsorption state, then we should increase the dose to 1 to 2 milligram per kg. For acrodermatitis enteropathica, it's 3 mg per kg per day. And zinc has been proven to be useful in diarrheal treatment. And less than 6 months, we should give 10 milligram per day for 10 to 14 days. More than 6 months, 20 mg per day for 10 to 14 days. So WHO has studied this effect of zinc in acute diarrhea. So zinc can reduce diarrheal episodes by 25%. And also there is a 30% reduction in the stool volume also. So they concluded there is a significant beneficial impact of zinc in children with acute diarrhea. Zinc also has toxicity, usually up to 10 times of the dose is tolerated, but acute poisoning can occur in when somebody has consumed 1 to 2 grams of zinc sulfate. And usually it's symptomatic management, and chronic intake, it should be like more than 100 milligram per day can be associated with copper deficiency also. So these are all the some of the problems with zinc toxicity. Yeah, that is the end of my class. And any questions, I can take it now, or you can send the comment, I can answer to that.
have put down the chat box now, or maybe mail to sir also. So for patients who have this abdominal pain, kids, infants or babies, or how do we approach them in terms of giving PPIs or any medications for colic abdominal pain, incessant cry, associated with diarrhea or non-diarrhea?
So yeah, abdominal pain is like a huge chapter. It's a different, like functional abdominal pain is more common in children. So most of the time we should look for the red flag signs for the abdominal pain. So mainly like abdominal distension and any diarrhea, blood in stools, vomiting, and poor feeding. So these are all the red flag signs for the abdominal pain. If these things are there, then probably we have to evaluate for that. So otherwise, for colic, as you talked about colic in between, so colic usually will give supportive treatment and burping, and sometimes dicyclomine helps. Other than that, most of the time it's functional abdominal pain. And if the red flag signs are there, based on the red flag signs, we should investigate the child.
PPIs?
PPIs is we should not use commonly in children unless until there is a specific gastritis symptoms are there, including the epigastric pain. Along with that, they are having like any drug intake and other associated symptoms are there, then we can give PPI.
There's one question which has been dropped down, sir.
Yeah.
Do we have to supplement vitamin D syrup to all infants, sir, according to the reason?
According to the WHO guidelines, yes, because all the infants, because nowadays I think our newborn also is practicing giving vitamin D drops for all the newborn babies who is getting discharged. Yes.
So the next question, low birth weight in neonates do they need zinc supplements?
No, zinc supplements is usually not indicated even if they are low birth weight, unless until like if there is any features of zinc deficiency presence, like if the child develops any symptoms of zinc deficiency, then probably we have to supplement. So usually they will develop like say recurrent infections, and they may have recurrent diarrhea, or they may develop skin changes. So at that point, probably we have to check the zinc and then supplement. So otherwise, diarrheal episodes itself, we can give zinc supplements.
What about measuring and supplementing for vitamin A?
Vitamin
A.
Vitamin A, no. Vitamin A, we are not measuring very regularly. Vitamin A, again, by clinical findings, we have to go for vitamin A. And usually, we will supplement for all those who is having a chronic problems with the vitamin A, particularly children who is having chronic diarrhea and chronic liver disease. So they should be supplemented with vitamin A. There is no need to say like vitamin A level to say that there is a deficiency. Yes.
Any further questions? I think that's about it.
Okay.
One more thing as questions coming.
Okay.
2-year-old male child with hemoglobin 3 gram % with severe dehydration. Will correct as per protocol, or will reduce the volume to be correct?
No, this child, I think we should be very careful when the child is presenting with anemia and also severe dehydration. We should go very slowly only. So here correction, I would say, like even if you are planning for a full correction, it should be given over a long period rather than a short period of whatever recommended for 3 hours or 6 hours. So first and foremost is like if you may have to treat the hypovolemia also. So probably we may have to give some fluid and then correct the anemia also. We have to give some blood transfusion. But correction wise, we should go very slowly, and sometimes we should monitor these children for failure and give Lasix if needed.
Hoping that answers the question. And then any further questions? I think then we'll wind up soon.
Sure.
Thanks a lot, sir, for this lecture. Very detailed and simplified for an PG level basis. This lecture soon be uploaded on the Department of Medicine YouTube website for anyone who missed out on it. Thanks again, sir, and thanks to all. We'll conclude.
Yeah, thank you, Anju. Thank you for everyone. Thank you, everyone.